According to a recent study, abdominal pain accounts for roughly 7% of all ER visits to US ERs annually. Doesn't seem like a lot, but when you factor in the sheer number of people who go to the ER, suddenly 7% can reach into the millions of visits. Your test results came back and you still have pain. Everything is negative, there's no appendicitis, but something is still wrong. You're still not feeling good. You're still having nausea. Is the medication not helping? Is there something more sinister going on that what's being tested for? Is your ER doctor just incompetent? Let's not answer the last one. What if I told you that your abdominal pain could be due to your diet? In this episode of the JAFERD Cast, we're continuing the debate regarding diet and how processed foods relate not just to your metabolic health, but perhaps that unexplained abdominal pain as well. So grab the Pepto. This episode is definitely going to give you heartburn. Welcome, everyone, to this episode of the JAFERD Cast. I am your host, Dr. Mark Pappadakis. Nobody particularly special, just another friggin' ER doctor. So today, we're going to be talking with the GI and Hepatology Fellow, Dr. Karolina Siniakowicz. We're going to be talking about gastritis, peptic ulcer disease, and basically stomach pain, a very common complaint in the ER and one that many of you have mostly after eating, well, Taco Bell and places like that. So if you enjoy the content, please be sure to like and subscribe, follow along. We're on Apple Podcasts, YouTube, Spotify, and social media. If you have any comments, suggestions, or if you want to be on the show as you're a medical professional, please reach out to my email at jefferdcast@gmail.com. Good to meet, good episode. So let's bring Dr. Karolina Siniakowicz in here. Hi, Karolina. Thanks for joining me. Welcome aboard.
Hey, thanks for having me.
So you're a Two-Oral College of Osteopathic Medicine graduate, just like me, but you were in 2015, so you're ahead of me. And you went to do your residency at Hackensack. Is that correct?
Yep.
And that was internal medicine?
Yeah.
All right. And then you're fellowship trained, went to Colorado, and you're technically GI and hepatology trained. Now, we talk about a lot of, stomach pain. People come in for abdominal pain a lot through the ER. So I wanted to bring a GI doc and you on here to mostly talk about when we are stumped in the ER that we can't really find a cause for abdominal pain. So we kind of chalk it up to, oh, it's probably gastritis, could be an ulcer, have fun, see a GI doc. And unfortunately, a lot of patients in my population, the spicy food, the greasy food is a very common denominator. And I feel like that's a main cause. Am I not wrong in that here?
I would probably say I would add a more common denominator, and that would be chemical substances like alcohol. That's the
Yeah.
most common I see.
Yeah, good call. I usually try to avoid mentioning alcohol because that makes me feel bad. I like, I like beer, I like all those things and wine and all. So
Yeah.
if I start saying alcohol, it's like, oh, I should probably change my diet around here too. But nobody wants to do that. So what do you normally deal with in your practice? What, chief complaints are more common do you see coming into your office? Do you get a lot of your referrals? What's the deal?
Yeah. So I happen to practice in a community. So we see a lot of community referrals. So I see a lot of patients who are coming in with GERD, postprandial fullness. So fullness after eating. I all of a sudden eat and I feel very full. Nausea and vomiting, extremely common. Abdominal pain, just unspecified. I have abdominal pain. And then I would say the two most common would be either significant constipation or diarrhea. And those are,
I love that there's like two
probably
extremes there.
yeah,
It's like
those are like majority of my patients.
I can't stop
then,
going and I can't go at all. It's like,
Yeah,
okay.
all problems. And then I would probably say a third of my patients I actually see for liver.
Okay. Again, alcohol related, I'm assuming, or is it like a combination of?
I would say right now the biggest thing is more patients are getting diagnosed with non-alcoholic fatty liver disease, and that would be the metabolic liver disease associated with diabetes and high blood pressure. And those are incidentally found on imaging. They went to the ER for a broken rib and someone CAT scanned them, and all of a sudden they say, well, you also have fatty liver and you should see someone for it. So I usually see them.
So interesting, because I feel that when we think about fatty liver disease, we think of your obese patients, diabetes, but you mentioned high blood pressure in there too. How does that end up working? How does that contribute?
Yeah, so, high blood pressure, high cholesterol, all of those, if you were to think about the syndrome of the metabolic X syndrome, right? So you think about someone who has diabetes, they may or may not be obese. I actually see a lot of patients who are not even obese. Maybe they're a little bit overweight, but they have some genetic predispositions to fatty liver disease. For example, their entire family has high cholesterol. The entire family has vascular disease. So they've had heart attacks at age of 50. Those are the patients
Yikes.
who I see who are 30 years old and they are coming to me with already stage 2 fatty liver disease. And maybe they drink a little bit of alcohol, but it's kind of, a more complex picture. And how do you prevent progression for those patients?
Can
So
you actually
that's
prevent
what we do.
progression? Is it
Yeah.
reversible?
Yeah. Yeah. For sure.
So basically, they just have to abstain from all the not great things for the body. And then ideally, what happens when we talk about fatty liver? I mean, is it just liver encased in fat? Does it get reabsorbed? Does everything just normalize?
So, I mean, the way that I describe fatty liver disease to patients is imagine if you have your entire liver. Over time, any stressor to the liver, the way the liver responds to it is by inflammation. So we call that hepatitis. Most people get a little skittish around that word, but that really just means inflammation of the liver. So let's say you drink a lot, so you binge drink on the weekends, but during the week you drink nothing. Let's say maybe you have slightly high cholesterol, maybe you have a little bit of high blood pressure, maybe you're pre-diabetic. All of those things create the perfect storm for your liver to become inflamed. So once in a while, you'll have an episode where you'll have maybe right upper quadrant pain, and we'll say, maybe it's your gallbladder. But realistically, it's probably hepatitis. It's probably inflammation of the liver. And if you capture that patient, you may see elevation of liver numbers, slight, but not a ton. And then you'll say, well, okay, your liver's inflamed now. And we do some fancy testing. We do some fiber scans. Sometimes patients even need a liver disease or a liver biopsy. And in those cases, we diagnose you and we say, which stage of fatty liver disease do you have? And then the problem is, how do we make it better? And it's not just abstaining from alcohol, because how do you fix your risk factors, right? So these patients would be, good candidates for maybe a cholesterol medication. Maybe we put them on a statin, see if that improves liver health. Nowadays, a lot of patients end up on these medications like, Ozempic and Mounjaro, and they end up on these GLP-1 analogs that help them lose 10% of body weight because that's really the goal. The goal is to lose 10% body weight to decrease the fat reabsorption into the liver.
We're seeing just a common denominator in now in a lot of episodes, how nutrition, lifestyle really plays a role in many different forms of disease. And obviously there's a big push now in healthcare and elsewhere to talk and address the quote unquote root causes of disease, which I think is interesting that we're told that doctors never address the root cause of disease. And yet here we are talking about the root cause of disease.
People don't want to hear the root cause of the
Well,
disease.
that's the key here. Yeah. We tell them about the root cause of disease, smoking, diet, and it's like, la 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 la. Obviously you discuss diet with your patients. We talk about medication, discipline. If you don't have the discipline, you can need medication, things of that sort, the triad. Have you referred patients to a dietitian or started patients on diet plans? How does that end up working out?
Yeah, so our group is really, really unique because we actually have a group of dietitians that work with us specifically. And what they do is they have access to my medical chart so they can see what testing the patients had done. And they're not just nutritionists, because that's a big difference. When you see a nutritionist versus seeing a registered dietitian. Okay. So people don't understand that. And the way that I describe it is a nutritionist is somebody, to me, it's the same difference as seeing like a nurse practitioner or a physician's assistant versus seeing a doctor. The training is very similar. It's the extent of training and it's the extent of licensing. So we work with registered dietitians. These are people who have trained for several years. They've been in clinical practice. They've been in hospitals and they are state board certified for diet for basically nutrition. And what they do is they talk to the patient. They have like a 5-prong assessment and they say, what is your sleep like? What is your stress like? What is your diet like? What are your bad patterns? And they even sometimes do heart rate variability monitoring and they say,
Interesting.
hey, can we see where your triggers are? And I work with them not only for my patients with with metabolic liver disease, but I send my patients with inflammatory bowel disease to them. And when a patient sees a dietitian, IBD patients specifically, they don't get rehospitalized as frequently. Their disease is better
Go
because,
figure.
yeah, because they are more compliant with their diet. So yeah, I utilize our dietitians. I would say probably, except for the very, very few patients who are very straightforward, IBS patients, they go straight to them. I don't even tell the patient that there's an option of not seeing them just because I know they will do better. They're very resistant to do it because that's the pattern that people are in. They like what they like, but I don't leave that as an option to them. And over time they like to do it.
Now, do you see, you mentioned like IBS, for example, do you see a common denominator in diet specifically that seems to trigger these types of patients, your dietitians? Do you see something of that sort that you can say, okay, this seems to be more of a common problem than this, for example?
Yeah. So I have kind of like a dual theory, I guess. So you mentioned fatty foods and spicy foods, and those are kind of, they may or may not cause an issue, but from my experience and my perspective, the big umbrella term is really processed food. That is your number one, right? And then number two is dairy. That is number two. Always.
It's funny you mentioned dairy because I've known a couple of colleagues who really have started to notice changes in their overall health as they've gotten older and they've cut out dairy and notice a significant improvement. And we talk about dairy and lactose intolerance, it's more of like a spectrum of disease. You can be lactose intolerant and only have a little bit of gas after eating some ice cream, or you can be full on lactose intolerant and be in the bathroom for the next 5 hours after you drink a little cup of milk.
Or have
And
severe
or
constipation.
severe constipation.
Yeah.
And ideally, the human body really is a unique organism in the sense that we're the only species that drinks milk after we've been weaned.
Yeah.
So now
We're not meant to do it.
we're not meant to do it.
We're not
And,
meant to do it.
people can obviously do it. And I am thankful that I can, eat ice cream and have cereal with milk in it. But, I know many people who cannot. They have some shades of this. And it's all based on the enzymes in the gut that break this protein down. And even a little bit of GI upset can be a potential trigger. So it's interesting that you guys are looking at that much more closely than I think the medical establishment as an overall is. That's just my opinion. Obviously, a
Mhm.
narrow opinion. What do I know, right? Just a year doc over here. But so you mentioned obviously milk, and you talk about processed foods. And are we talking your TV dinners here? Are we talking like little fruit snacks? Like when you say ultra, like we're talking like everything. What's the ultra?
Everything. Everything that comes in a plastic package, it is considered processed, really. Because, when I talk to patients, I get very, kind of honed in on their actual history because they'll come to me with random symptoms. And for most people, those symptoms are a mystery. And they'll say, well, I mean, none of it makes sense. But once you get really good history, and this is where, medicine is a little bit of detective work because some patients are terrible historians.
Yes, 100%.
So that's where the magic kind of happens in the office where you say, all right, well, my favorite question to patients is walk me through your, morning, afternoon, and dinner routine. What do you eat? And then I hear, for the morning, I skipped at breakfast. I don't have breakfast. I have coffee and then I have a snack. Well, what's your snack? A power bar. Okay, great. Healthy.
Yeah. Yeah. Uh-huh.
Okay. And then lunch. What do you eat for lunch? Well, sometimes I'll pack a lunch. What do you have for lunch? Well, I have, a sandwich with cold cuts and a bag of chips. Okay,
Okay.
cool. Healthy.
Mm-hmm.
You
Yeah.
didn't get McDonald's, right?
Right,
Uh,
exactly. Saving money, I'm
yeah.
making my own lunch, I'm not
Yep.
ordering out. Uh-huh.
Yep. And I'm healthy. And I get a lot of patients who come to me and they say, I have a healthy diet. What am I doing wrong? Why do I not feel well? And then, for dinner, they'll have something that's maybe pre-made. So they'll have, maybe some sort of like they're working and, maybe they have spaghetti, but they bought the sauce from a can or from a jar. Still relatively healthy,
Right,
not the end of the world when you think about it. So,
right.
these are the patients who have chronic problems and they say, I cannot pinpoint what the food is. and they come to me seeking food allergy testing, which I absolutely refuse to do. I will never order a food allergy test because useless for GI completely. Unless you have angioedema and you're swelling up and you have a rash after eating it, boom, that's your food allergy.
Yeah,
But,
and there's a difference,
you
and
know,
this is very common among many patients, the idea of an allergy versus an intolerance. It's medications, it's foods, it's everything. Just because you have a negative reaction to something doesn't mean it's an allergy. It means your body isn't tolerating it to some degree, whether it's known, like a side effect of a medication, or unknown, like, you're eating this processed item, whatever it is, and suddenly, hey, my gut's not feeling too hot. I'm having this issue. Yeah, that's technically more of an intolerance, and there's no way to test for that. The test is removing
eat
that
it, don't
substance,
eat
and
it.
don't eat it. Exactly.
So yeah, so I typically do a lot of counseling for patients, and I tell them, if you look at the ingredients and it's not just the ingredient, tomato or whatever else, and no preservatives, that is technically processed. If there's preservatives in it, it's processed. So,
Yeah, and you
it's tough.
it's tough, especially because we have a society, and again, we don't want, going back to the root cause comment, right? We have a society that's go, go, go. You're working more than 40 hours a week. You're working overtime. You're working two jobs. You are pressured to stay late, come in early, and that is obviously terrible for circadian rhythms. I mean, you have night shift workers, late shift workers, and crying out loud, ER doctors are notorious for that. And as a result of that, you have unhealthy habits, not unhealthy diets necessarily, like you just said. What that person ate was quote unquote healthy. It wasn't fast food, wasn't candy bars. You're not eating quote unquote junk, but it's unhealthy habits that's leading to these chronic conditions, these chronic diseases. And I am guilty of that. I will be the first to say that when I come home from a 2 to 11 shift, a 3 p.m. to 1 a.m. shift, I'm starving because I'm snacking through most of my shift. And I come home and I eat a TV dinner at 2 o'clock in the morning because I'm famished and I can't go to bed hungry. And they're what? They're chock full of sodium. They're chock full of, cholesterol containing stuff, fats and oils and whatnot. And it tastes great. It hits the spot. And then, I don't feel great after
Right.
eating it,
Yeah. Yeah. I mean, that's something that I tell my patients, and they love this term. I call it the restaurant syndrome. And the best way to figure this out when you're talking to a patient is when you're making food for yourself, do you feel sick? And when you go out, do you feel sick? Because I have a lot of patients who come to me and they say, oh my God, I feel sick all the time. And I ask them, how many times a week do you go out for dinner or do you go out for lunch? And it doesn't matter if it's a healthy lunch or if it's an unhealthy lunch. How many times a week do you actually have food that is from a restaurant? And people don't understand that in a restaurant setting, unless you're really in going to a really, really fine dining restaurant, farm to table, where they are making everything from scratch to order, you are getting food that is processed. You're getting food that has preservatives because they have to. They can't have food sitting out and poisoning you. So it needs to have some form of preservative. So, when I kind of rephrase that and frame it in that way for patients, I say, when you're making yourself food, you know exactly what goes into it. You know every ingredient that goes into it, and you can pronounce that ingredient. When you're going out to a restaurant, things are going to be, by all accounts, more fatty than you would make it yourself, unless you're, I don't know, really a huge fan of butter.
Yeah.
But it will
And
be more
lard and
fatty
all
because
that good stuff,
yeah, yeah, because fat is tasty. So what is the goal of a restaurant? Is to make tasty food. No one is going to go unless you're going to like a vegan, clean restaurant. Every other restaurant will be focused on the flavor. So they want you to come back. They want you to have a tasty meal that I will never forget that steak. Well, guess what? That steak was like 2,500 calories.
Yes, yes.
Get a nice ribeye, put a ton of butter on it, get some
Mhm.
mashed potatoes. I mean, that is like a whole meal for two, in one sitting. So,
And when,
so
of course,
that's one of the things.
you're gonna walk away from that meal, and what are you gonna do? You're probably gonna go sit down. You may go for a little bit of a walk, but those 2,000 calories are just gonna, like, percolate in your system.
Yeah.
You're not gonna burn it
And
off.
no, and the thing that people don't understand, and once I kind of tell them this, they're like, having an awakening in my office. And, I usually tell people to go and watch the YouTube video of the McDonald's burger. Okay. You've
Yes, I'm
seen this,
familiar with
right?
that one.
Yeah.
Mhm.
So it was like years ago, 10 years ago.
Yeah.
If a food is meant to be shelf stable, okay, for days, weeks. We buy bread that's in packaging and it's good for 3 weeks. And it will pretty much never grow mold unless you live in Florida and it's really hot. If mold doesn't want to grow on something, it is so processed that imagine putting that into your body. Your body is going to double, triple, quadruple the amount of acid to just digest it. And that's how, GERD and heartburn and dyspepsia, none of those things are created by a stomach that doesn't work. It means your stomach actually is
Doing its
pretty
job.
working
Yeah, it's
pretty
actually
darn
doing its
good.
job pretty good. Now, it's actually doing a really good job to the point where it's
It just makes
overproducing
you
this
not feel good.
stuff. Yeah.
Exactly. And it makes you feel unwell. And, that's one of the things that people don't understand is that there's nothing wrong with your body. What you're doing to it is not right because, your body, and without going into like a theological debate here, but our bodies, whoever designed it, it is designed perfectly. That's just the way it is.
Hmm.
There are some diseases, there are some genetic disorders that aside from that, but the way your body is made and the way your body is connected and your body's digestive system works, it's designed perfectly. We cannot make it better.
And
And,
it's designed for, thousands and thousands of years of evolution. It's fine-tuned itself for this purpose
yeah,
too. It's not just,
yeah,
slapped and here we are. This is something that has gone on thousands of years of advancement, perfection, if you want to call it, to now we're just kind of punishing it by giving it garbage.
exactly.
It's
And there's a reason why, my husband and I went on a trip to Switzerland. And I'll tell you a funny story. So I grew up in Poland and I came here, I was 16 and I was never lactose intolerant. I am severely lactose intolerant in America.
interesting.
When
Okay.
I go to Europe, I can eat whatever I want. So I know that I'm not lactose intolerant. I know that I am intolerant to whatever the processing thing is happening to specific foods. Because if I have a more imported cheese, I'm okay. If I have milk, I will die. So,
Interesting. Yeah.
yeah,
I mean, I don't want to interrupt your story there, but
yeah,
do
yeah.
you know what about the process between European food and American food is different? Has that been looked at, studied?
I mean, there's all kinds of studies. There is nothing that they can pinpoint. They're always going back to the, you know, GMOs and the fact that, in America we're feeding all the animals corn. Corn is actually a very, very highly pro-inflammatory food. And it is not an easily digestible food.
You say that as I just ate corn on the cob 2 nights ago.
Yeah.
Now I'm feeling
Yeah.
guilty. All
So,
right.
but that's the thing. Just adding corn into our system, that's one of the big differences because cows are not meant to eat corn. Just a shocker for everybody, but they do. Same with all the flock and all the chickens that we're eating. So I think that's one of them, but the processing here is different. The pasteurizing process, there are additives that are getting added to the pasteurizing process. No one's like really talking about it. It's not just heating it up. So, even in European countries, you go and have a pasteurized milk. That milk still, if it sits on the counter for 3 hours, it will go sour and it will start separating. American milk doesn't do that.
Yeah. Oh,
It
I
doesn't
know.
do that. It
I left
really
that on the counter
doesn't,
for a while and it's still pretty good.
right.
We just put it in the refrigerator.
Yeah. Yeah. So there is some processing that takes place that really takes away the good bacteria, I think. And I think that if you were to measure the amount of bacteria and the probiotics, the natural probiotics that are in the dairy, it is much higher in Europe. I think the natural lactobacillus that likes to be in lactose is so high in those. And that's why you get the sour cream and that's why you get the milk with the cream on top because the bacteria in it is constantly replicating. But the problem with the American food industry is that, we're feeding millions and millions and millions of people. You're not feeding a small country of, Switzerland,
Right.
where,
Right. Yeah.
the
The food supply is
comparison
more
is
central. It's
different.
easily, it
Right.
takes 2 hours to cross the country versus,
Right.
several days by plane or something, or by
Correct.
train.
Correct.
And
So that's the big thing,
yeah.
and I hate to just blame it on, the food industry and the society and whatever, but as a person and as a patient, you just really have to do your best, and your best has to be what is not actively making you sick. And that has to be the priority, that you cannot continue to ingest food that your body is actually just physically rebelling against. And that people don't put those two things together frequently. So the change is hard.
And look, I've been railing on, RFK Jr. here for many reasons. It does make it difficult because there is a kernel of truth into his crazy, lunatic, unhinged rants about things, which is processed food is a problem. But the difference is the medical community has recognized processed food is a problem. How do we go about improving it and regulating it to make it better for us has always been the question. And, looking at what other countries do is a very good first step. So you talked about, Switzerland, Poland, all them. What do European countries do that we don't do? Can we replicate that? And like you said, we have a large country to feed, and we feed other countries too from our food supply. Other countries, we export a lot of our grains, we export our meats and everything. So, how do you balance shelf stability and preservation with health? And that's it's almost like an oxymoron in a way. You really can't do that to the exact perfect degree where it's completely healthy and it's completely shelf stable, unless we're in Star Trek and you're talking about replicators.
And add the third component of affordable,
And
right?
affordable, that's a good point too. So now you have
Yeah.
this triangle of affordability, preservation, and health, and you can't do it. You're going to sacrifice one or two to make one better. It's a discussion that we're not going to answer, obviously, today, or even I'm probably never going to answer on this show, but it's something that the medical community is aware of, that we are trying to advocate for and working towards, but there are ways to do it that won't harm us and will actually make improvements.
Yeah.
I want to
And,
say,
and
not bullshit
at the end
improvements,
of the
but yeah.
day, yeah, I know, but at the end of the day, I think that you can only do your best. That's number one, right? And number two is we can do better. We can make better choices, and those choices don't have to necessarily be, more expensive. It comes down to education, and it comes down to changing mentality and willingness to even approach it.
The
Uh,
willingness is the
you
key
know,
too. Are you
yeah,
willing to
and yeah,
it's easy to take like red 40 out of your fruit snacks, but at the end of the
right.
day, a fruit snack is still a fruit snack. A Pop-Tart is still a Pop-Tart. You're not making it overall healthier by saying, well, we're removing artificial dyes, so now it's healthier. It's not.
Right, you're not making it safer, you're just making it less toxic.
Right.
That's
Right.
it. You're
Yeah.
not making it healthier. I think you have to, like, make a big differential of removing toxins. I don't understand how that's even, like, non-priority. It should be the priority. Making food healthier is not equivalent with making it non-toxic. Healthy food should not be toxic, obviously, but a non-toxic food still can be unhealthy. So
Correct.
that has to be a very, like, clear line. You're like, "Yeah, I'm taking out food dyes, but it's still a
It's
freaking
still a
Pop-Tart."
Pop-Tart. It's still a freaking Pop-Tart.
Like, we haven't changed that. But yeah, and I always tell patients that, part of the GI like office visit, one of my questions for majority of my patients is if I feel that their symptoms are tied to their diet, I always tell them, are you willing to do the work that is required for you to feel better? It will be long lasting and you will feel great. I guarantee it. Like 100%. Or do you want to be on a medication? And guess what? And some of them just choose the medication and they say, I'm not changing what I'm doing. And that's fair, but that question I have to ask because I on it, and this is just God's honest truth, I can't afford to spend 45 minutes trying to convince you to do something you're just not going to be willing to do. So I'm
That's
not
my
going to counsel on a diet that you are just telling me you're not going to follow. It is pointless for me. I will still give you the information and I'll say, listen, I'm here for you. I'm willing to talk to you about your diet. But you have to tell me that if I'm going to go through this whole thing and do the diet assessment and make you food, do a food journal, you're willing to try it, even for a month.
mhm. I would
But
say
a
at
lot
least
of
a
times
month.
yeah.
I mean,
And a
it
lot of
has to be
times
at
I
least a
just get a
month.
no. Yeah. And I just get a no. No, thank you. I'll take the pill. And I say, all right, great. So
And that leads to my next question, which is how long are your visits typically for your patients? We talk. So she's laughing because there's a lot out there about how I saw the doctor for 15 minutes and we didn't talk about anything, whatever. And then they'll go somewhere that's less busy, maybe not as specialized, and spend an hour. And then the patient feels great. I spent an hour there, and then they'll be sold supplements or a book or some kind of 1995 diet plan here.
mhm. Yeah, yeah. So my office visits are scheduled for 15 minutes. 15 minutes each. Now, if I have a patient who is more complicated, like my IBS patients, I'm never there for 15 minutes. That's a 25 to 30-minute visit. And I go over time and then I apologize to my patients and they wait for me. But I always tell them that, I'm behind because I'm not going to run out of the room and say, I'll see you later. Right. So, which I wish I could sometimes, but I can't. Um, and it's just not in my heart to do that. So, yeah, some patients are more complex. They require that time, and I'm willing to give them that time if I feel that they are actually going to do it. Um, you know, I'm certainly not going to sit there and this is me being very honest. Like, I'm not going to sit there for 35 minutes talking to an alcoholic who I've seen 5 times. And every time I see him, it's in the ER because they're intoxicated. And I've told them multiple times that they're going to die and they're leaving their family behind. And I've thrown everything at them.
Hmm.
I'm just not going to spend that time because I have somebody else who is going to benefit from that more. Am
And
I
it
going to
sounds,
spend that time with someone who is, going to benefit? Yeah, of course.
yes. And it sounds cruel. It sounds like, well, that means you don't care about the person. No, no, no.
I care a
I hear
lot. I
you.
freaking
You
lose sleep
care.
over those people.
Yeah, you try, but at the same
Yeah.
time, it's the old saying, you can lead a horse to water, but you can't make them drink. At the end of the day, with anything, with any medical therapy and any specialty, even emergency medicine, at the end of the day, if the patient is not going to do the thing that you are suggesting and you give them valid reasons for doing these things, then you're just wasting your own energy. You're wasting your own mental health in trying to get these patients to try and follow the science or try and follow your line of thinking to try and get themselves healthier. At the end of the day, there are patients who they just want a pill. Give me the pill. I'll be on my way. Thank you very much. Okay.
And you know what? In some cases, that is okay. Like, in those cases, if you're an 88-year-old lady and you're just like, my stomach is
Yes.
killing me, and you're sitting here telling me that I shouldn't drink my glass of wine, God bless you, lady. Please, I will send you any medicine you want. You have your wine. You're 88 years old. Like,
I
fine,
think I have a
super. I
rule.
like congratulate you.
I have a rule. I think if you're over the age of 80 or maybe even younger, I don't know, but at least over the age of 80, you can eat and drink and do whatever the heck you want at that point. Like, we're
Yeah, I
done.
mean, you got yourself there somehow, So,
Exactly.
but that's the thing, it's kind of like that Jerry Maguire, help me help you. Like,
Yes.
help me help you. And
Yes.
I can't, those people who are the ones that are non-compliant, that they're not going to do what you think is best for them or that is best for them. It's not that they're not worth the effort because I've had some people turn the corner and you're always available for them. I'm always available for my patients. I'm never going to say, I will not see you because you drink. I don't care, but I want you to try something. But that's kind of the reality of medicine that a lot of people kind of poo poo medicine these days and they say that we're not there to keep them healthy. Well, where are you keeping yourself
Yes.
healthy? Like, I'm not going to go
Yes.
home and clean out your fridge and tell you you can't have Cheetos at midnight. I'm going to tell you that. But then you're going to say, well, my doctor is a skinny girl and she doesn't know anything about a diet. Well, like there's reasons why some doctors are fit and some doctors are not fit. And those doctors who are not fit, yeah, I would agree with the patient. Like, you look at a
Hmm.
doctor who's morbidly obese, don't tell me what to eat.
Right.
I don't want to hear it,
Yeah, exactly.
right? So practice what you preach. And, I try to practice what I preach. I still have a glass of wine and a beer or whatever and a meal out in a restaurant? Yeah, of course. But that has to be with the knowledge of like,
This is what
this
I'm
is
getting
good.
into. This is what I'm doing.
Is my
It's
doctor going to yell at me because my
Yeah.
labs
Like,
are
wait,
weird?
it's like they're seeing you at the restaurant having a glass of wine. It's like, wait a second, you told me that's unhealthy, and you're just like, yes,
Yeah,
I did, but this is
yeah,
my once a week cheat day or something.
right,
I don't know.
right, yeah,
But yeah, it's a level of personal responsibility now. It's a shared responsibility. It's I'm partially responsible for you and your health, yes, but you have to be responsible for acknowledging what I'm telling you and acknowledging that this habit, I agree, is unhealthy. I mean, we see it with smoking, right? I have a patient who comes into the ER and it's a diagnosed heart attack, and we ask them, all right, so, listen, what's your medical history here? And he says, oh, high cholesterol, whatever. My father had a heart attack and, I smoke. Do you still smoke with all that says? Well, I quit. Oh, good. When'd you quit? About an hour ago and I had my chest pain. Oh, okay. Okay. Well, yeah. You talk about length of visit and, obviously in emergency medicine, it's difficult for someone like me to have these conversations with patients. And when the patient is in the ER, no matter what you're here for, it's not a good day. And if it's for something that's like, your stomach pain, it's hard for me to talk to a patient and say, your CAT scan came back fine. Your blood work came back fine. Maybe your LFT is a little bit elevated, whatever. But overall, there's no infection. There's no signs of a heart attack. There's no signs that your appendix needs to come out. There's no signs of anything that needs to be addressed now that you need to be admitted for. Well, I'm still in pain. I'm sorry. Well, I can give you some medication to help you through the pain, but it's going to take days. It's going to take weeks. It's going to require follow-up and an acknowledgement that says maybe something is here that needs to change on your lifestyle. And I don't have that extra 30 minutes, 45 minutes after, when everything is said and come back to say, okay, now let's talk about your diet here. Like, I can't do that. And unfortunately, many patients that I care for have no primary care doctor, let alone have the time to take out of work to go see someone like you, to go see that specialist that has that conversation. So when you have a society that doesn't allow for that to happen, when you have a shortage of physicians, of not just physicians, I'll expand it for now, of qualified personnel to help a patient get healthy, then you're going to be left with an unhealthy population, an unhealthy society. And as a person who sees people on their worst day, as a person who sees the end stage complications of bad choices, it's frustrating, and it's frustrating on many reasons. One of the reasons why I'm doing the show is to try and get this stuff out there. But at the end of the day, too, there needs to be a level of personal responsibility that you cannot help the patient with. It needs to be done by them. And ideally with family, with a support group too.
Yeah, and you mentioned, patient coming to the ER and you telling them, all these things. And I think a couple things that are helpful are, and I know every patient gets this and they throw it in the garbage, but the handouts that come from the ER, like
Yes.
this is maybe what you have, like, and I have that at my office too. And I even use like a transcription tool to write down things that we discussed during the visit, and I give it to the patient. Like, listen, just I know we covered a lot, but I want you to really pay attention to these like four things. I even sometimes write on a post-it note.
Hmm.
So, when it comes to patients like that, the ER is tricky, because you guys are really in the worst position out of everybody in healthcare, because you are there as, when you train, you're there to do emergency
Hmm.
medicine.
Yeah.
And some people treat you as a primary doctor.
Yes.
So that is the problem. The problem is that there's a discrepancy with the patient expectation and what is the reality of your job. Your job description is emergency medicine. A stubbed toe is not emergency medicine, and chronic GERD that has been going on for 25 years, it is not emergency medicine. But people go to emergency rooms because they don't have a primary care doctor who's
Hmm.
available to them,
Yeah.
or they don't have one at all, or they don't have health insurance,
Yes.
or they, are so sick that now at this point they don't have access to medications. They are not educated enough to do anything over the counter. So it's a really complex problem that you guys deal with. But at the end of the day, patients need to understand that the reason they are in the ER is to rule out all the big bad stuff. And
Yes.
when you don't find big bad stuff, guess what? You get to go home.
And I often will
You don't
tell
get
them,
to,
yeah, and I'll often tell them, I say, hey, good news. We didn't find
right.
anything. And some patients who come for a diet, who come fearing the worst, are relieved. But then the
Right. They'll
patients who are
say, I thought I was having a heart attack.
correct.
Great.
Yeah, it's like, oh, thank God.
Super.
I thought it was appendicitis. Oh, it's not. Oh, thank God. And then the patients who are there for a diagnosis get frustrated. I say, well, then why am I having pain? I don't know. And I say that a lot. I tell my residents, as I said, it's okay to say to a patient, I don't know. If you truly don't know and you've done the things that you can, because you can say, I suspect it could be gastritis. I suspect it could be an ulcer, but ultimately you're going to have to follow up. And the GI doctor, if we're suspecting an ulcer, is going to have to do an endoscopy, is going to scope you to actually visualize it to make sure, yes, it is in fact an ulcer. Here's how we need to approach and treat this thing. But oftentimes, unexplained abdominal pain, I will sometimes say it's probably gastritis. And is that always the case? Or is it just, there could be food intolerance, or is it maybe a combination of both here? What do I say to the patient when
Yeah,
they
yeah,
say, I don't know what's causing your abdominal pain?
yeah. Well, I think there's a couple things. When you have a patient who comes and they have, let's say they just have epigastric pain and they say, my stomach hurts. When patients say their stomach hurts, you really have to just differentiate which part of their stomach hurts because the stomach for a patient is anywhere from like here all the way down to
No,
their
they're
pelvis.
correct. Yep.
That's the
Yeah.
stomach. So you need to figure out that's step number one, really, and that's going to help you figure out, you know, functionally what it is. So they say, okay, I have, my stomach hurts here. You figure out if it's, and really, when we talked about, just to kind of backtrack, we talked about the 15 minutes, of the visit, right, in my office. And I'm not like tooting my horn. This is like a very standard thing that most GI doctors understand. I can diagnose you probably in about 5 minutes. I don't need more than that. I will ask you the right questions that I feel like will lead me to it, or at least to get you like 90% there.
Yeah.
That's all I need.
Yep.
I need 5 minutes. And, with the questions, you ask them, is your pain worse or better with food? And just my favorite question ever is, have you had this pain before? And if they've
Yes.
had this pain before and they say, oh yeah, I've been having it up, back and forth,
Months, years. Yeah,
months,
exactly.
years, whatever. So I basically put patients in like three categories in my brain. I say either they've had this pain for 30 years and it just happens to be the worst it's been, but it's been there, right? Number two is they've had some sort of pain, but not like this. This is a different type of pain. They've had their chronic reflux. They say, oh, I take my omeprazole or whatever, and I'm taking it, it's not working. And then this is different. This pain is different than my normal type of discomfort. And then you have the third type of patient who is like cruising through life, eating garbage, and then all of a sudden they wake up one day and they feel awful and they've never felt like that before.
Usually after you hit
You know?
30. That's,
Yeah.
when I've noticed that for myself.
Or I'm 50 and I'm falling apart.
Yeah. Yes.
That's
Yeah.
what I hear. So basically those people are, in the emergency room setting, I think that's what you really just need to pay attention to. Did you have this pain? It just happens to be the worst, but it's really the same type of pain you've had. And those patients, I may or may not scope. I may think, there's some, it's just like a functional disease. This is something that's more dietary. This is more lifestyle. A lot of patients actually have just untreated constipation. They
Mm,
don't drink enough water. They have
yeah.
other things in their lower GI tract that are giving them upper GI symptoms. The most worrisome patient to me personally is the middle patient, is the patient who's like, yeah, I have GERD, but like this is different. This is different than my GERD,
Yes.
you
And
know?
that's what
Yeah,
triggers me as the emergency physician as well, because we're not snide when we ask that question in the ER, how is this different than usual? Like, we're not trying to play a gotcha. You don't need to be here. It's
right.
no, no, I need to know this because your GERD could actually be a heart attack. Like, if
Yeah,
you're like, well, I have
exactly.
chronic reflux, but actually, this is like different. It's like going up a little bit higher or something like that.
Yeah,
Okay, I need an EKG. Like,
yeah,
there are triggers, and you mentioned this, you see it, trigger words, trigger phrases that get us like, ooh, this is not good. Okay.
yeah, yeah.
So
Yeah, so
100%.
from yeah, so for me, it's, and when we talk about gastritis, right? So gastritis, and not to be like a jerk or anything, but gastritis is a histological diagnosis. What most people refer to a gastritis is they're just referring to, dyspepsia, meaning just in indigestion, really. So when patients come to the ER and they say, I have epigastric pain, and to me, they for me to even think that it's this, stomach or any part of the GI tract related, it has to have some relationship with food. When someone comes in and they say, "Yeah, my stomach really hurts, but it only hurts when I walk." Super, you're having a heart attack.
I go upstairs, I'm a little short of breath. Are my lungs okay? Oh, sweetheart, it's not your lungs.
That's the big thing. So for me, it's, does it get worse when you eat or does it get better when you eat? Do you feel better eating? Have you lost weight because you're really not eating as much as you used to? And how long has this been going on? And then you have, all your other types of questions. But, the most worrisome patient for me is going to be somebody who says, I have GERD and I take pantoprazole every day. I take my Nexium every day. And today I woke up and I took my Nexium and then I just still have discomfort. So then I took a second Nexium and then I took some
Yeah.
Tums, and then I took some Pepto-Bismol, and then I came to the ER.
And then, and
This
then,
is a
and then.
patient,
Yep.
yeah, and this is a patient who worries me. This patient may have an ulcer because guess what? They've already given themselves a treatment for an ulcer and it's not working. So what is it, right? So those patients, scope them quickly. And I mean, relatively quickly. If they're admitted, that's a different story. But if they're outpatient, that is the person who on our initial visit, they're going to get scoped. The patients who are the once off, like, I have an iron stomach and today I feel awful. Those patients, I probably wouldn't even recommend scoping. They don't even need GI workup. They need, some form of acid suppressant for 2 to 4 weeks. Give them a trial of that. If they break through it, great, send them over.
Mm-hmm.
But aside from that, they really don't need that. So in places where seeing a GI doctor may take 3, 6 months, that exists.
Yep. It's
You
6 months
know,
for us. It's,
so
even, we're
my
not a healthcare
waiting
desert
list
either, but
is,
yeah.
yeah. So my waiting list is about 2 months, but ER patients, I'll see them quicker. But the big thing is those patients I'm not worried about. This happened once. This could have been food poisoning. This could have been really anything. And that's one of the other things that I would say, food poisoning, you're not going to diagnose in the ER. You're going to say all of my tests are negative and
Mm-hmm.
you still could have gastritis from bacteria. And that will just go away and you can treat them, you can give them things like Carafate and you can give them a PPI, you can give them famotidine, you can give them, there's within the GI world, we only have like 6
Yeah,
medications
it's
for
true.
like heartburn.
It's true. And it's like nothing else
You're
is
either,
working. It's like, I got nothing,
right,
man. This is
right,
it.
exactly. There's nothing else. So and when patients are like, hey, I took all those things and now those things are not working, those are patients who I'm thinking about other things. They probably have H. pylori or they have an ulcer and they need just really intensive therapy for that ulcer. So, it's most GI patients, they don't get diagnosed in the ER. They really don't, because the only way you're going to diagnose an ulcer is if they're perforated
Mm-hmm.
or
Yep.
if they're hemorrhaging, right? So if they're coming in and they're unstable,
Yeah, they're all of a
those are
sudden
the people. They're so sick.
your black tarry stools, or you vomited like coffee ground looking stuff that gets our
Hmm.
attention, very quickly. And those are the
Yeah.
ones that are admitted for, what we need to scope you here because this is bad.
Yeah.
Could
Yeah.
be
Or,
bad.
yeah, someone comes in and they're like, hey, I like my goody powder and, my both of my hips are broken and, I take ibuprofen and I leave twice a day. Those things perk your ears up a little bit. But aside from that,
Yep.
most patients, in terms of GI stuff, you may really not get a diagnosis aside from the stuff you would actually take
Be
them
able to
in
diagnose.
for an admission.
Yeah.
The
Yeah.
cholecystitis, the appendicitis, like those things, it'll be a slam dunk diagnosis. Everything else aside from that, in my world, needs an endoscopy from my perspective.
And I'll never forget a case. I had a patient who was a chronic Motrin, NSAID user for chronic pain. I think it was like back pain or something like that. And, worsening abdominal pain. And immediately, like, again, like you say, it takes you 5 minutes to get a diagnosis. Sometimes it takes us the same, right? You ask a couple of questions and you're like, it's this.
Mm.
And as soon as they said, "Oh, it's NSAIDs, I have back pain, and my stomach is not really hurting, probably an ulcer." We get a CAT scan for completeness' sake, because they were tender, and we're like, "All right, we gotta check this out here." And the CAT scan radiologist, the report actually showed that there is an ulcer in the stomach. You actually see it on CAT scan. It was that large, and this thing was probably moments away from perforation, just because of how large and erosive it was on that CAT scan. And that was the first and only time I've actually seen peptic ulcer on CAT scan. I was able to actually
Yeah,
diagnose somebody
never
like,
good.
you have a peptic ulcer because we see it on CAT
Yeah.
scan. Oh, that's great. No, it's not. I can see it on CAT scan. It's not a good thing. So, Dr. Karolina Siniakowicz, thank you so much for coming on. We had a great conversation. Hoping to get you back on for other topics and even updates to this one if you're so inclined.
Sure.
So we talked about, obviously, diet being a big factor in people with stomach pain, gastric upset, dyspepsia, and overall lifestyle. And of course, we talked a little about gastritis and peptic ulcer disease, but ultimately things can just go back at the end of the day to diet, lifestyle choices, lifestyle modification. Very underrated. We're starting to become more aware of it now as a society, even though doctors were pushing for this for, decades at this point. But some really good information. So thank you so much for coming on. Really appreciate it.
Yeah, my pleasure. Thanks for having me.